Okay, Professor Ihab.
Yes, we'll start.
Yeah.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد. With you today, Professor Ihab Salim, Professor of Diabetes and Endocrinology, the ex-head of Diabetes and Endocrinology Unit, Zagazig University, founder and president of ISMA. Welcome to all attendees. Today is the first ISMA International Cardiology webinar in collaboration with the Heart Failure Working Group of Egyptian Society of Cardiology. ISMA is the abbreviation of Ismailia Metabolic Syndrome Association. This association is specialized as a study cardiometabolic risk factor and its associated comorbidities. And of course, heart failure is one of the most important comorbidities will be discussed today. Today, I happy to welcome Professor. The last week we have the first ISMA International webinar on diabetes on participation of Professor Abed Al-Tahrani, the senior lecturer of endocrinology and diabetes Birmingham University, United Kingdom. Today, the 7th of July, the important date in the history of ISMA, the day we are all waiting, the first international ISMA webinar. I feel proud to introduce our dear guest, Professor John McMurray, Professor of Medical Cardiology, Deputy Director of Institute of Cardiovascular Disease and Science, a Medical Science of University of Glasgow, UK. It is a honorary consultant cardiologist in Queen Elizabeth University Hospital, Glasgow, UK. He published about 700 paper and review. He is a primary author and editor in many journals. Today he will discuss. He will his talk today is about heart failure update 2020, focus on pharmacological treatment. We are he have a very well strong CV will be presented in detail by our dear Professor Magdi Abdel Hamid. Professor Magdi, I will happy to pleasure to introduce Professor Magdi Abdel Hamid for the first time in ISMA webinar. Professor Magdi Abdel Hamid is the immediate past president of Egyptian Society of Cardiology. He is the current president of Heart Failure Working Group. It's our pleasure to welcome Professor Magdi Abdel Hamid, not only as a director, but also as a speaker today and will talk today about heart failure practice in Egypt. We are lucky to meet Professor Magdi again after 10 days in the ISMA National webinar about non-communicable disease. I'm honored to present and introduce my dear friend and my success partner, Professor Ahmed Tajuddin Abdullah, Professor of Cardiology, Suez Canal University. He is a co-founder and president, vice president of ISMA. He talked today about global burden of heart failure. I also wanted to great thanks to Professor Ahmed for his great effort in organizing this wonderful meeting. Our partnership in foundation of ISMA is based on multidisciplinary approach. And our tag or slogan is ISMA is together we do better. Finally, I extend my great thanks to Novartis company and the team for ongoing support for all CME activity in general and in particular for the sponsorship of this meeting. I hope that we have a fruitful scientific day. And now I will leave the floor for Professor Magdi Abdel Hamid for moderation of this meeting and welcome to all attendees. Thank you. Please, Professor Magdi.
Thank you very much, Professor Ihab, for the kind introduction. Good evening, everybody. Welcome to the ISMA International webinar in collaboration with the Egyptian Society of Cardiology, the Working Group of Heart Failure. First of all, I'd like to thank Professor Ihab Salim, the founder and the president of ISMA, for the kind invitation. Professor Ihab is one of the experts in the field of diabetology in Egypt. And also I'd like to thank my dear friend, Professor Ahmed Tag, Professor of Cardiology at Swiss Canal University, the co-founder and the vice president of ISMA. And Ahmed is well-known cardiologist in Egypt, one of the very active cardiologists, and he has a special interest in electrophysiology. Thank you, Ahmed, and congratulations for a lot of activities that you are doing nowadays. And thank you, Ahmed, for your great initiative to invite Professor John McMurray and giving us the opportunity to meet with him in this webinar. Professor McMurray, we are delighted to have you with us today. He is well known, one of the pioneers in the field of heart failure all over the world. Of course, he has a long CV, so Professor McMurray is a well-known expert in the specialty of heart failure, and he has been leading many clinical trials in heart failure for decades. He has a great contribution to the field of heart failure, of course, we know that, and he is considered a mentor for many cardiologists all over the world, and I'm proud to be one of them. So thank you very much, Professor John McMurray, for accepting the invitation to be with us today. Thank you very much. For the attendees, I'd like to welcome all attendees who are attending this webinar, and I hope it will be an interactive webinar, so I strongly encourage all of you to actively participate in the discussion by asking questions at the end of each presentation, and the questions will be answered by the speakers as well as the panelists. So for the sake of time, I have the pleasure to introduce my dear friend, Professor Ahmed Tag, and he is going to talk about the global burden of heart failure. Go ahead, Dr.
Ahmed. Thank you very much, Professor Magdi Abdelhamid. I'm just trying to share the presentation. It will be with you in a few minutes. And now, so yeah, we are back again. Thank you very much, Professor Magdi Abdelhamid, for your presentation about this important webinar about heart failure. It's important for many reasons. Our guest, Professor John McMurray, and I wouldn't say more than what you have said about him. He is a very successful scientist. He is a leading expert of heart failure, I would say worldwide. He asked me not to make a very long CV of himself, but his H-index in Google Scholar is 172. My Google Scholar index is 12, and I'm very proud of that. 172. He's keep telling me not to say that. Anyway, he is an eminent professor. He's very humble, and he is the mentor of my mentor in the UK, Professor John Cleland, which I'm very grateful for being with him for a long time in the UK. And he always talking about Professor McMurray ideas, thoughts. I myself attended with Professor McMurray for short time in Glasgow, and as well in the Edinburgh Royal School. Actually, there was a talk of 2 hours about the paradigm trial and heart failure. Anyway, I'll go for my talk now. Global burden of heart failure. This is much for an educational grant, non-promotional one. They are our success partners in most of ISMA activities, CMEs, meetings, webinars, and workshops as well. So many thanks for them, and thanks as well for IRSD organizing a company for that. What's ISMA in 2 minutes? ISMA is the Ismailia Cardiometabolic Syndrome Association, founded at 2018. Founder, Professor Ihab Salim, which I'm very honored to work with him. He's very expert in metabolic and endocrinology, and diabetes has own specialty. Our mission is to reduce the cardiometabolic risk and burden in Egypt. Our goal is to improve the practice and prevention of and management of cardiometabolic syndrome components. Our strategy is to have multiple continuous medical education sessions, improving practice, sharing experience, and our vision together do better. Just started 2 years ago. However, we have done 5 successful national meetings, 75 CME lectures, workshops, 3 international webinars. This is one of them. Collaboration with the Egyptian Society of Cardiology, Egyptian Cardiac Rhythm Association and Working Group of Heart Failure, collaboration with the Endocrinology Society in Egypt as well, more than 1,000 participants from Suez Canal area and all over Egypt. So this is a resume of ISMA in 1 minute. So this is my topics today: the growing epidemic of heart failure, WHO key facts about cardiovascular disease and heart failure epidemic, cardiac remodeling, the key of heart failure vicious cycle, and a brief resume of heart failure morbidity and mortality. So if we go to the growing epidemic of heart failure, prevalence of heart failure is somewhere between 2 and 3% worldwide, more than 7% in the elderly, more than 50% of patients with impaired left ventricular systolic dysfunction are asymptomatic. Prevalence of heart failure with preserved ejection fraction is nearly equal to heart failure with reduced ejection fraction, and actually both have the same burden of mortality and morbidity. It's expected that the prevalence of heart failure is projected to increase by at least 50% in the next 20 years, because of changing demography of population, more elderly patients, improved survival of cardiovascular disease, especially acute MI and heart failure itself. If we see this diagram here, the prevalence, as say, is increasing with age up to 1 in 5, which means 20% when patients are between 70 and 80 years, growing incidence, growing prevalence worldwide because of aging, improved post-MI survival. This is a recent paper published by a group of heart failure experts worldwide, speaking about the incidence and prevalence of heart failure and the most common causes. And you can clearly see that the most common causes are ischemic heart disease and hypertension. This is very important graph representing the projected incidence of heart failure and the actual incidence of heart failure in USA. And this paper is published 2018. And this figure was projected at 2011. You can clearly see that from 2000 and up, the curve or the line, which is the dashed line, exceeded what's projected. Simply, this means that heart failure is a very rapidly growing epidemic. And not strange that heart failure with preserved ejection fraction is equal or even more than with reduced ejection fraction in hospitalization. And it's more common in females as well. This diagram, again from the same paper in Circulation 2018, represents that heart failure presents the most common cause for emergency department visits, hospitalizations, and mortality. So this is actually a very growing epidemic. What about the WHO key facts about cardiovascular disease and heart failure? So let's start with this, like scorpion, the is cardiovascular disease, and the tail is the war. And those are the most common causes of death worldwide. So heart failure and circulatory disorders are the most common causes of death worldwide, according to WHO 2017. And there are some numbers to remember, and I will take this expression from my colleague, Professor Ihab Salim. Usually is interested about numbers in cardiometabolic disorders. So heart failure and cardiovascular disease, #1 cause of death globally. More than or about 18 million people died from cardiovascular disease in 2016. 31% of them of global death, actually. 85% are due to heart failure and stroke. 75% of cardiovascular death actually occurring in low or middle income countries, and Egypt actually is one of those countries. So it's a global epidemic. So what about cardiac remodeling and the heart failure vicious cycle? When there is a primary myocardial injury, like an ischemic heart disease, post-myocarditis, chronic hypertension, volume overload, pressure overload, this leads to endothelial dysfunction, neurohormonal activation and dysregulation, and secondary myocardial effects, LV remodeling, impairment of contractility, eccentric hypertrophy, apoptosis, release of cytokines, fibrosis, and so many pathophysiologic changes, which lead to, at the end of the day, to sudden cardiac death, progressive pump failure, and symptoms. And if you look carefully here, that with cardiac remodeling due to cardiac myocyte and extracellular matrix damage, for example, due to MI, this leads to cardiac remodeling, which leads to further remodeling. Because of inappropriate remodeling and progressive negative aggravation of LV dysfunction, hemodynamic changes, which leads at the end of the day to heart failure. And this is actually the natural course of heart failure. From the onset of the diagnosis, where patients, they don't have any problem except some shortness of breath, and then limitation of movement, and then restriction of movement, and then being bedridden. And this actually is happening across the further steps of irreversible cardiac dilatation due to various neurohormonal dysregulation, which lead to high heart failure mortality and morbidity. The good news that there are some predictors of reverse remodeling. Some of them is non-ischemic etiology, shorter duration of heart failure, lower ejection fraction, strange enough, and absence of late gadolinium enhancement, and low biomarkers like NB, NT-proBNP. If you have those in your patient, it's likely to have reverse remodeling. However, the bad news in that usually most of heart failure patients, they have the criteria of adverse remodeling, like high BNP, positive gadolinium enhancement, longer duration of heart failure, and ischemic origin of cardiomyopathy. What about the heart failure morbidity and mortality? As I said before, from onset of diagnosis to the projected time of death, there are lots of hospitalization and rehospitalization. And with each hospitalization, the chance and probability of death is more and more, because heart failure is a progressive disease with cardiac structures, as you see here, and functions continue to deteriorate. Risk of rehospitalization for heart failure patients is disproportionately high in the first 30 days after first hospitalization. 44% of heart failure patients are readmitted at least once for any cause during 1 year follow-up, and 25% 1 month readmission rate for all cause rehospitalization. You can see here clearly that hospitalized heart failure patients have a 2.5-fold increase in mortality risk compared to heart failure patients who are not hospitalized. So keeping your patient away from hospitalization means keeping your patient away from mortality. Worsening of heart failure symptoms make a 6-fold increase in risk of all-cause mortality, and 5-fold increase on all-cause mortality in patients with worsening symptoms. And that's actually is very, I would say, shocking data, but that's what we have in heart failure. Actually, there is a work by Professor McMurray, who is our guest today, and from Merit Heart Failure. Sudden cardiac death accounts for approximately half of death in patients with heart failure. The proportion of sudden cardiac death is still there in NIHA functional class 2 and 3 heart failure. What about the burden of heart failure in Egypt? We have a very great work by Professor Magdi Abdelhamid, again our guest today, and Professor Mahmoud Hassanin from Alexandria University. This is the Egyptian Heart Failure Registry, a large registry with the European Society of Cardiology, which reported that 68.8, about 70% of heart failure patients were hospitalized with acute heart failure, while 31% had chronic heart failure. So hospitalization for heart failure, either as first-time acute decompensation or chronic heart failure, is there, accounting for 70% and about 30% of patients. And in our department, Suez Canal University, we have conducted 2 studies, one at 2015, and we have reported that the short-term mortality rate was 24% in patients admitted with acute heart failure. And we have also reported in another research at 2016 that the long-term heart failure mortality was 16.3, and heart failure hospitalization more than once per year was about 60%. And this is going with the international flow. This is the story of heart failure therapy, and I wouldn't go for that long story because Professor McMurray will do this job, but this is just a summary of that from just the dressed to pharmacological with the digitalis, diuretics, vasodilators, then neurohormonal intervention, then devices, CRT and ICD, then everabradine and 2010. And with this all medications, 50% with heart failure will die within 5 years of diagnosis. This is another shocking number that we have to search for actually a solution for that medical treatment, of course, or even surgical intervention. So what about the new therapies for heart failure, for which Professor McMurray will talk about, like ARNI, sacubitril, valsartan, in which in paradigm heart failure, led by, again, our guest professor McMurray, it lead to 20% reduction of risk of reduction of cardiovascular death, first heart failure hospitalization, 20% reduction for risk reduction for sudden cardiac death, 16% risk reduction of death from any cause, 23% fewer hospitalization for heart failure, and 18% fewer days in intensive care. So this is actually one of the greatest heart failure therapy studies published in New England Journal of Medicine. And by the way, Professor John McMurray is one of the editorial board of the New England Journal of Medicine, very prestigious and very highly scientific academic journal. And actually, after that study, there are many studies, paradigm, titration, transition, and so many studies with sacubitril, valsartan, caring about heart failure patients. We hope that this will have some repercussions in future in these days, actually, for our patients with heart failure. And this is the new therapies of heart failure, which I think Professor McMurray will talk about. I think sacubitril valsartan is no longer new in heart failure. SGLT2 are expected new generations, intravenous iron, cardiac myosin activators, and many other medications for heart failure in the pipeline. This is my take-home message, Mr. Chairman and Professor McMurray. The global burden of heart failure prevalence is about 22 million adults worldwide living with heart failure in USA. Comorbidities, heart failure patients usually have more than 3 comorbidities. Hospitalization, it's #1 cause of hospitalization worldwide. Mortality, 50% of heart failure patients die within 5 years of diagnosis. And economic burden, I think you all know that it's costing so much money, about 110 billions a year, according to USA data. And I will end up my discussion or presentation with this word from one of heart failure patients. And this was published by the, I think, British Heart Foundation. This is a patient describing his status of heart failure. It's like growing old overnight. He's describing paroxysmal nocturnal dyspnea. So it's like growing old overnight without gradual aging that gives you the chance to adapt. 2017. Thank you very much for all attendees and our panelists. And the microphone back to Professor Magda Abdelhamid and Professor Ihab Salim. Thank you. I have stopped sharing. Professor Magdi?
Professor
Magdi?
Yeah.
Professor.
Thank you very much, Professor Ahmed, for this elegant presentation, as usual, Ahmed. I have one question, as long as you are one of the experts in electrophysiology in Egypt. So we know that sudden death in heart failure is around 50% mortality. So prevention of sudden death is very important. As long as we have new therapeutic options which have a favorable effect on remodeling, like sacubitril valsartan, and the prevention of sudden death, as you mentioned in the paradigm study. So we know the guidelines recommendation for ICD as a primary prevention, which is class 1. But if we have drugs which can prevent sudden death, like sacubitril valsartan, MRA also prevents sudden death, beta blockers the same, So for primary prevention, can we consider that these drugs can be used without the need for ICD?
Thank you very much for this question, and I think Professor McMurray will have a say on that. However, sacubitril valsartan has a very fast intro to the guidelines within 3 months in EU and within 6 months in USA. And from the first year of its introduction, I think at 2015, 2016, by the European Sociology, they admit that it's a class 1 level of evidence A in reduction of ventricular arrhythmia. Before being introduced as one of the important therapies for heart failure, it was class 1 level of evidence A. So it could be as adjuvant therapy for prevention of sudden cardiac death due to ventricular arrhythmia, of course, not due to bradyarrhythmia. However, sudden cardiac death in heart failure for main bulk of heart failure patients is due to tachyarrhythmia, VT or VF. However, in about 25 to 30%, it's due to bradyarrhythmia, and this happening with advanced stage of heart failure or due to drug effects. Sometimes patients on digitalis or beta blockers, if they are over beta blockaded or with digitalis or even with amiodarone, they have bradyarrhythmia and they could pass away simply because of bradyarrhythmia. So I would still go for ICD for indicated patients for primary prevention, along with sacubitril valsartan for primary prevention. Thank you. Professor McMurray, do you have a say?
But Professor McMurray, I want to take your opinion regarding this question, and I'd like to add, do we need a CMR study to assess the scar characteristics to see a reduction of this scar before and after therapy to identify if the drug has a favorable effect on the substrate which is inducing ventricular arrhythmias?
Okay, so there are lots of questions. So firstly, whether or not sudden death is a major driver of mortality depends on the severity of heart failure. So in patients with predominantly mild symptoms like paradigm, then the major mode of death is sudden death. And I agree, obviously, in most cases, that's probably due to ventricular tachyarrhythmias. I mean, as you know, the role of ICDs is questioned a lot. It's very interesting when you do large trials like I do to see the enormous regional variation in use of ICDs. So, for example, in paradigm heart failure, I think ICDs were implanted in 55% of patients in the United States. But in Latin America and the Asia Pacific region, it was about 5% of patients. So it's a huge difference. So that reflects economics, but it also reflects different views about doctors and using ICDs. As you know, the Danish trial suggested that in non-ischemic cardiomyopathy, at least when it comes to all-cause mortality, ICDs may not reduce all-cause mortality in patients who are very well treated with other drugs and devices. Now, that doesn't mean that ICDs don't have a role, but it maybe means that we have to be more careful about whom we implant ICDs in. And you've raised the issue about not just etiology, but whether there's some other characteristics, clinical findings that can help guide us as to whether or not somebody is suitable for an ICD. And obviously one of those things potentially is scar burden identified using CMR. But in fact, we don't have good evidence for that yet. There is a study running, but at the moment, we just don't have that evidence. It's a nice idea, but whether it will turn out to be the case or not, I don't know. It reminds me a little bit of the story about myocardial viability as a basis for choosing who should or should not undergo surgical coronary revascularization. And the Stitch study really didn't confirm that that was a useful approach. So whether or not a scar burden will be a useful approach or not, I don't know. The only thing I would say is that in our own hands in Glasgow, our referral of patients for ICDs has decreased a lot. And that's because we find that with very good pharmacological treatment, so many patients increase their ejection fraction to above 35% that we don't actually feel there is an indication for an ICD anymore. So if you think about patients, you think about who you would exclude: patients with very severe symptoms, patients who are very elderly, patients with a large burden of non-cardiovascular comorbidity. It's actually a relatively modest number of patients today, I would say, have an indication for an ICD. But the bottom line is they're still a very valuable part of what we can do for patients with heart failure. But it's an interesting moving target. You may also know, and this is my last comment, that the ESC was talking about trying to set up a study to look at whether or not ICDs still have a role even in ischemic cardiomyopathy patients with heart failure, in ischemic etiology. There was so much of a reaction to the Danish trial and the demonstration that there was no mortality benefit in non-ischemic cardiomyopathy. People even began to question whether with modern drugs and devices there was still a role in patients with an ischemic etiology. So it's definitely a very interesting, very hot topic, I would say, still today.
Great. Do we have other questions from the attendees? Do you have questions, Dr. Ahmed, Dr. Ashraf? You didn't send a question for us?
No question till now, Dr. Magdi. No questions till now.
Okay. So I know that we will have a lot of questions after the presentation of Professor John McMurray, because he will open through this presentation, the attendees will be stimulated to ask many questions. Especially the lecture will focus on contemporary management of heart failure. So we are expecting to see a lot of questions regarding the new drugs, the mechanism of action, how to use the guideline-directed medical therapy in everyday clinical practice for patients with heart failure. So Professor John McMurray, go ahead.
Thank you very much, Magdi. Thank you very much for inviting me to join this meeting tonight, and thank you for all the people who are spending their evening watching this webinar. So I'm going to try and give you an update on heart failure. I'm going to concentrate on the past 5 years approximately, but I actually spend most of my time focused on the past year. So let's start. So I'm getting my slides to move. So you've already heard this trial mentioned, the Paradigm Heart Failure trial, and that's where I want to start this recent journey. So I'm going to ignore all the other drug and device trials that we've heard so much about and have been so valuable. I'm going to start my story about 2014 with Paradigm Heart Failure. And you've heard about this trial and you know about why we did this trial. So this, just so that it's clear, because sometimes I think people can be a bit confused about what Paradigm was about. Paradigm was about testing a new approach. So it was testing a completely novel approach to the management of heart failure. And that novel approach was inhibiting an enzyme called neprilysin. So inhibiting enzymes, very familiar approach in cardiology, obviously angiotensin converting enzyme ACE, statin, CHMG-CoA reductase. This is another enzyme discovered in the late 1960s in the UK, and it's an enzyme, in fact, that we've been trying to inhibit, find a way to do that safely and effectively in patients for a very long time. In fact, the first study done with a neprilysin inhibitor in human beings was done in Glasgow, believe it or not, back in 1989. So it took us 25 years to find a way to do this successfully. And the reason that we've been trying to inhibit this enzyme was because it's the enzyme that breaks down natriuretic peptides, A, B, and C type natriuretic peptides. Those peptides secreted by the heart, by the blood vessels, by the kidneys, and these peptides are secreted to protect the body against volume and pressure overload. Those are the body's natural defenses against states or situations, circumstances like heart failure. So we thought if the body produces these peptides in patients with heart failure, if we could augment that production, we might bring about benefit to patients with HFrEF. So of course, eventually Novartis produced this combination of valsartan and sacubitril. Valsartan, of course, you know very well, it's a RAS blocker, but this was the new entity, neprilysin inhibition using sacubitril. And the Paradigm Heart Failure trial, very simply, was a test of a neprilysin inhibitor on top of conventional triple therapy versus no neprilysin inhibition. And you saw this figure earlier, 20% relative risk reduction in the primary composite endpoint, and indeed a reduction in cardiovascular mortality of 20%, a reduction even in all-cause mortality. But even the best trials have weaknesses, are open to criticism, and leave gaps. And that was true of Paradigm Heart Failure, just like any other study. And these were the main things that doctors asked about Paradigm Heart Failure. The comments they made included the fact that we'd only included patients who were on existing therapy with an ACE inhibitor or an ARB. They said that we didn't include patients with new onset heart failure. It was frequently commented that we only included ambulatory patients and that we hadn't studied sacubitril valsartan in hospitalized patients. And of course, that's a great opportunity to start any drug in patients with heart failure. Our American friends complained that we had not included enough patients of African descent. And probably the single most common comment made about the design of Paradigm Heart Failure was that we required a run-in period during which all patients had to tolerate full dose enalapril and then tolerate full dose sacubitril valsartan. So it was frequently commented that we didn't know whether or not lower doses were beneficial in patients with heart failure. And that is why this study, which was published last year, called Pioneer Heart Failure, was so important, because this study filled many of those gaps that I've just mentioned. This was a rather small study and it was short term, but nevertheless, it was very important. As you can see, it was a study conducted in patients who'd been hospitalized with heart failure, so that was a key gap that was filled. And it enrolled patients irrespective of whether or not they had a prior diagnosis of heart failure, so they were de novo patients, and it enrolled patients irrespective, regardless of whether or not they'd been treated with an ACE inhibitor or ARB. And as you can see here, there was no run-in period. So patients were randomized to sacubitril valsartan or to enalapril. As I said, it was a very short-term study. There were only 8 weeks of randomized treatment to either sacubitril valsartan or enalapril. The reason for that was it was considered unethical to leave these patients on enalapril for more than 8 weeks, because we clearly demonstrated the superiority of sacubitril valsartan over an ACE inhibitor. So this was a short-term study for that reason. These are the patients enrolled, and it's very important to look at these patients because, as you can see here, more than a third of the patients were of African descent. So remember, that was a criticism of Paradigm Heart Failure. About a third of these patients had no previous diagnosis of heart failure, so a third of patients were de novo presentations. And also, very importantly, just over half of the patients had never been on an ACE inhibitor before. And of course, these patients had a much higher NT-proBNP than in paradigm heart failure. In fact, it was about twice as high because, of course, they were enrolled during an episode of decompensation leading to hospital admission. Now, because this was a relatively small and short-term study, the primary endpoint was a biomarker endpoint. So the primary endpoint was reduction in NT-proBNP. And you can see here that compared to a RAS blocker alone, adding an neprilysin inhibitor to a renin-angiotensin system blocker reduced NT-proBNP. And in fact, we learned something very interesting in this study, and that was just how rapidly neprilysin inhibition decreased NT-proBNP. Within 1 week of randomization, you can see that there was this clear reduction in NT-proBNP, presumably reflecting left ventricular unloading, reflecting a reduction in left ventricular end diastolic pressure, left ventricular wall stress. And in fact, in this study, if you read some of the follow-up papers, there were reductions in many other biomarkers, including, interestingly, troponin, reflecting cardiomyocyte necrosis. Here is what happens during the 8 weeks of treatment in terms of patients achieving the target dose of therapy. 55% of patients got to full dose sacubitril valsartan. About 60% of patients got to full dose enalapril. So this benefit was observed despite the fact that not everybody achieved the target dose. So that's a very important finding because we did not know whether this would be the case because, of course, in paradigm, everybody started treatment at the full dose of these two drugs. You can see here the tolerability profile. So even though these were patients who've been hospitalized with decompensated heart failure, you can see that most patients did not have an adverse event. And actually, you can also see that the adverse event profile of sacubitril valsartan was pretty much identical to the adverse event profile of enalapril. So both of these treatments were well tolerated. We know ACE inhibitors are well tolerated in this setting, but here's evidence that sacubitril valsartan was really as well tolerated as an ACE inhibitor, even in these recently admitted patients. But the most interesting finding in this study was this pre-specified composite clinical outcome. So this was a composite of death, hospital readmission, left ventricular assist device implantation, or listing for cardiac transplantation. And even though this study had only about 850 patients in it, you can see, 880 patients in it, you can see that there was a significant reduction in just 8 weeks of treatment, when an neprilysin inhibitor was added to a renin-angiotensin system blocker. Now, of course, there were not many deaths, and I think there were no left ventricular assist device implantations. This endpoint was principally driven by heart failure readmission, but nevertheless, that is a very important and worthwhile goal of therapy. And you can see here that there was a 46% risk reduction, as I said, in this very short period of follow-up, 56 days or 8 weeks. Now, normally, in a study of only 880 patients that lasted only 56 days, I would be a bit skeptical about whether this was a real finding or a chance finding, were the investigators just very lucky that this worked out well, or is it real? But actually, I think it probably is real, because if you go back to the paradigm heart failure trial, when we examined this early period after randomization, in fact, these Kaplan-Meier curves were statistically significantly different within just 30 days of randomization. So in fact, I believe that that very early benefit probably is true, and that in fact we've seen this now in 2 studies with sacubitril valsartan, 2 studies showing that the addition of an neprilysin inhibitor to standard therapy further reduces morbidity and mortality, and does that very quickly. So that was, in my books, one of the important recent studies, but the other important recent study from last year that I want to tell you about is DAPA-HF, which you also heard mentioned. And this was a study using a drug that was not terribly familiar to most cardiologists. And this is a drug that inhibits one of a family of sodium glucose cotransporters. And this particular one, SGLT2, is found, we believe, exclusively in the proximal renal tubule. There are other members of this family. SGLT1 is also found more distally in the nephron and in the gastrointestinal tract. But SGLT2, we believe, is just found in the proximal renal tubule. Now, these drugs had been introduced as a treatment for type 2 diabetes. In other words, introduced as a treatment to lower blood glucose. And the way that these drugs lower blood glucose was very different than any other type of diabetes treatment. And they do it because by inhibiting this cotransporter, what they prevent is the normal reabsorption of glucose filtered from our blood as it goes through the glomerulus into the glomerular space and the proximal tubule. But these cotransporters reabsorb all of that filtered glucose along with sodium from the proximal renal tubule. So normally, if SGLT2 is working and your blood glucose concentration is normal, no glucose appears in the urine. But if you block these cotransporters, if you block reabsorption of glucose, you increase urinary glucose excretion, you increase urinary sodium excretion. Of course, because you're losing glucose, you're losing calories, so you get weight loss. Because you're increasing sodium and water excretion as well, you get a reduction in blood pressure. So these drugs seemed a great idea, a great way to treat type 2 diabetes. But because in 2008, the US Food and Drug Administration had required all new diabetes therapies to prove cardiovascular safety, there was a trial set up with one of these agents, and it reported in 2015. And that trial was the EMPA-REG outcome trial. It was a trial in patients, obviously, with type 2 diabetes. All of these patients had atherothrombotic cardiovascular disease, so coronary artery disease, previous stroke. Very, very few of them had a history of heart failure. And yet, what was really striking in this study was this 35% relative risk reduction in heart failure hospitalization. And not only was there this very large relative risk reduction in these patients with type 2 diabetes, but as you can see here, once again, that effect was observed very rapidly. In fact, almost immediately after these patients were randomized. So this was clearly because 90% of these patients didn't have heart failure at baseline. This was clearly a demonstration that this SGLT2 inhibitor was preventing the development of heart failure, but it was also clearly a demonstration that this could not be explained just by glucose lowering. We know that glucose lowering is good in protecting against atherosclerosis and coronary artery disease, peripheral arterial disease, cerebrovascular disease. But that benefit of glucose lowering therapy takes years or even decades to develop. But here we were seeing a benefit in terms of heart failure hospitalization occurring within literally weeks of starting treatment. So this had to be something else. I would have to say that even to this day, we don't know what that something else is. Maybe these drugs just work by being a diuretic and reducing left ventricular preload and afterload. Maybe they do other fancy things. Perhaps they improve myocardial metabolism and energetics. They definitely protect the kidneys. But whatever it is they're doing, clearly they prevent the development of heart failure in patients with type 2 diabetes. But when we saw those data in 2015, we wanted to ask the next question, which is, instead of just using these to prevent the development of heart failure, could we use these drugs to treat patients with established heart failure? In other words, could we use them to treat prevalent heart failure rather than prevent incident heart failure? And of course, we had additional questions. So should we just focus on heart failure patients with diabetes? Or might these be a valuable therapy for all patients with heart failure, even those who don't have diabetes? And if we didn't believe the benefit of this treatment was due to glucose lowering, then there was no reason to exclude patients without diabetes. And then the harder question we had to think about was, should we study HFrEF? Should we study HFpEF? Or in fact, could we study both types of heart failure? We chose to study patients with heart failure and reduced ejection fraction. And of course, that study was the DAPA-HF study, which we presented last year at the ESC and published in November. And you can see the design of this study here. I'm not going to go through this in detail. These were pretty typical patients with heart failure and reduced ejection fraction. In fact, we largely copied the design of paradigm heart failure. We did exclude people with a very low EGFR, below 30. We did exclude people with a systolic blood pressure below 95. And importantly, we excluded patients with type 1 diabetes. These patients are at more risk of developing ketoacidosis with SGLT2 inhibitors, so they were excluded. There was no run-in. There was a single dose of dapagliflozin given once daily, no dose titration like most of the drugs we use in heart failure, and a very similar primary endpoint to the one that we use in every other heart failure trial. These are the baseline characteristics. Again, I would say pretty typical of all our other HFrEF trials, very similar to Paradigm, mainly male patients, because of course HFrEF is mainly a male disease. Most patients, nearly 70%, were NYHA class 2. In other words, had mild symptoms, again, quite like Paradigm. You can see here that the mean EGFR was 66, 40% of patients had an EGFR below 60. But most importantly is the bottom line here. 45% of patients had diabetes, 55% did not have diabetes. So that critically allowed us to test that question of whether or not dapagliflozin might be a treatment even in patients without diabetes. This is background treatment. You can see here that more than 90% of patients were on a RAS blocker, more than 95% were on a beta blocker, more than 70% on an MRA. So very, very good pharmacological treatment. Sadly, not as much use of sacubitril valsartan as we would have liked. But remember, this trial started in 2015, just after sacubitril valsartan was beginning to be approved. And you can see here we talked about device use. 26% of patients had a defibrillating device. That might not seem very high, but in fact it is as high as any other HFrEF trial. But as I said before, again, very regional, much more common in North America and Western Europe than in other parts of the world. So here is that primary composite endpoint. And you can see a number of important things in this figure. Firstly, that there is a 26% relative risk reduction in the primary endpoint. Secondly, that was highly statistically significant. Thirdly, the number needed to treat to prevent one patient having the primary endpoint was only 21, and that was over a median follow-up of 18.2 months. So that indicates a large absolute benefit. And then you can see here again this finding that we saw in EMPA-REG outcome of this early separation of the Kaplan-Meier curves. In fact, again, we've done a statistical analysis here, and these curves are significantly different within just 28 days of randomization. Now, when you look at a composite outcome, it's always important to look at the components. And we heard in the first presentation mention of ivabradine. And if you remember in the SHIFT study, while there was a reduction in heart failure hospitalization, there was no reduction in cardiovascular death. We saw a reduction in both components. So we saw an 18% relative risk reduction in cardiovascular death. We saw a 30% relative risk reduction in worsening heart failure events. This was mainly heart failure hospitalization. If you look at heart failure hospitalization by itself, there was a significant 30% reduction in heart failure hospitalization. And we talked a few moments ago about modes of death, and just as we discussed, because these patients had mainly mild symptoms, the major mode of cardiovascular death, so of course most deaths are cardiovascular, and the more common cardiovascular cause of death is sudden cardiac death rather than pump failure death, because patients with milder symptoms are more likely to die suddenly than they are to die from progressive pump failure. But you will see here that both of these modes of death were reduced to a similar extent by dapagliflozin compared to placebo. Now, of course, critical to the hypothesis underlying this trial was that dapagliflozin would be a treatment for all patients with HFrEF, not just patients with diabetes. And here you see that critically important subgroup. So here are the patients without diabetes. Here are the patients with diabetes, and you can see that the relative risk reduction was almost identical, 27% relative risk reduction in patients without diabetes, 25% relative risk reduction in patients with diabetes, actually statistically significant within each subgroup, certainly no interaction between treatment and diabetes status at baseline. But let me just point out to you something very important here, because in every country that I know of in the whole world, today you can use dapagliflozin as a treatment for diabetes. Whether your patient with diabetes has got heart failure or doesn't have heart failure, you can use this treatment for diabetes. And please look at what is called the placebo group here. Now, of course, by placebo, you will remember more than 90% of people on a RAS blocker, more than 95% on a beta blocker, 71% on an MRA. So these are actually very well treated patients. But look at what happens to them. If you have the combination of heart failure and reduced ejection fraction and type 2 diabetes, you have a very high event rate in a very short period of time. This is 24 months of follow-up, and you can see here in these people treated with conventional therapy, they had about a 1 in 3 chance of basically dying from cardiovascular causes or being admitted to hospital with worsening heart failure. Very high event rates. You can do something about it with dapagliflozin. You can see here the very substantial benefit to be gained. Now, in fact, in some countries, you can even use dapagliflozin in these patients who also get the same relative risk reduction, although they're clearly not at as high risk as patients with type 2 diabetes. And in fact, in May of this year, the US Food and Drug Administration was the first country in the world to give approval to dapagliflozin for the treatment of heart failure. So in the US, dapagliflozin has now got two indications. One is the original indication. It's had it for several years now, of course, as a treatment for type 2 diabetes. But look at this. It is now a treatment for heart failure. It is now, for us as cardiologists, one of our drugs to use. This is irrespective of whether or not patients have got diabetes. It's for heart failure with reduced ejection fraction, and it includes patients with an eGFR down to 30 mils per minute. And in fact, the US Food and Drug Administration fast-tracked this approval because they thought this had such important public health implications worldwide. And we've learned recently that this is now being approved in the same way in Canada, in India, in Switzerland, and I heard just today also in Singapore. So this is moving very rapidly. Remember, we only published these results last November, and by May, this treatment had already been approved. I've told you all the good news you need to know about the safety profile. When we set this trial up, we didn't know about the renal benefits of this treatment because we knew that SGLT2 inhibitors do act as diuretics. We were worried because we were giving them to patients, most of which were on a conventional diuretic. In fact, most were on a loop diuretic. They were virtually all receiving a renin-angiotensin system blocker, and as you saw, most were on a mineralocorticoid receptor antagonist. And when we started this trial, nobody else in the world had ever studied SGLT2 inhibitors in patients like the patients in DAPA-HF, in patients getting all of these different drugs as background therapy. So we were worried about these adverse events. We pre-specified them as adverse events of special interest, and we collected this information systematically during the trial. But as you can see, as it turned out, very few patients had these adverse events in either treatment group. And in fact, as you can also see, there was no difference between dapagliflozin and placebo. And then these other things that cardiologists worry about, hypoglycemia, diabetic ketoacidosis, very uncommon. 4 cases of hypoglycemia in each treatment group, and only amongst patients with diabetes at baseline. 3 cases in total of ketoacidosis, and again, only in patients with diabetes at baseline. Overall, only 10.7% of patients stopped study drug, and that was the same proportion in the dapagliflozin group as to the placebo group. Now, I could talk all night about DAPA-HF, but I'm not going to. But we've published a lot of papers since. There are many more in the pipeline. So if you're interested in finding more, you can read all about it in these various additional manuscripts. So I want to bring you right up to date with respect to HFrEF. And this is going back to just a few weeks ago when the latest of the HFrEF morbidity mortality trials reported. And that was a trial called Victoria, using a drug called vericiguat. Now, this drug has not been approved yet, so you can't use this at the moment, but it's an interesting drug because it is a drug that acts on an intracellular enzyme called soluble guanylate cyclase. Vericiguat stimulates this enzyme, and if this enzyme is stimulated, it results in an increased production of cyclic GMP. Cyclic GMP has downstream effects that we believe bring about actions that are beneficial in patients with heart failure. Now, this drug was of great interest to me because it shares some of the mechanism of action of sacubitril valsartan, because of course natriuretic peptides also stimulate the production of cyclic GMP. But of course we know that neprilysin acts on many other vasoactive peptides, not just natriuretic peptides. It acts upon bradykinin, adrenomedulin, and other vasoactive peptides that we believe may have beneficial effects. So there is a shared mechanism of action, but neprilysin inhibition has several additional effects compared to vericiguat. So the Victoria trial was quite different than Paradigm or DAPA-HF, and the main difference was that it enrolled patients who had been recently hospitalized or received intravenous therapy for worsening heart failure in a non-hospital setting, but effectively most of these patients had been in hospital very recently. And it also had a very high natriuretic peptide entry requirement. So by having these two inclusion criteria, this trial enrolled very high-risk patients. But actually, otherwise, they were quite similar to the patients I've already showed you, the patients in DAPA-HF, and indeed the patients in Paradigm heart failure. So once again, in their mid to late 60s, once again, predominantly male, only a quarter were female. But a big difference here, obviously, is that everybody had been in hospital, and most patients, 2/3, had been in hospital within the previous 3 months. In DAPA-HF, only 40% of patients had been hospitalized with heart failure. So this is one difference. And the second difference here, as you can see, this very high NT-proBNP level. This is more like the Pioneer study that I showed you at the start of my presentation. This is twice as high as in DAPA-HF. So the main differences are recent hospital admission, very high NT-proBNP. These patients were all very well treated with conventional therapy, just like DAPA-HF. So this is the primary composite endpoint. It's the same as Paradigm, the same as SHIFT, very similar to DAPA-HF, effectively the same as DAPA-HF. And there are three things, I think, to highlight on this slide. The first is, if you concentrate on the placebo group, remember, very well treated with conventional therapy. If you look along the x-axis, this is up to 32 months of follow-up, so just over 2.5 years. And here on the y-axis, you see the cumulative incidence, 55%. So you can see here that in the placebo group, about 50% of patients have the primary composite endpoint within about 2.5 years. This is an extraordinarily high risk population, much higher risk than in any of the previous studies. The second thing to notice is that although there was a significant benefit, the relative risk reduction was modest. So this is a 10% relative risk reduction. But remember, because the absolute risk in these patients was high, even this modest relative risk reduction translates into quite a large absolute risk reduction. So this is about a number needed to treat of around 26 patients. So although this might look a little disappointing, this is actually quite substantial. But the other thing that was maybe disappointing about the Victoria trial was that when you look at the components of the composite outcome, you can see that while there was, again, a 10% relative risk reduction in heart failure hospitalization that was statistically significant, the difference in cardiovascular death was not significant. the relative risk reduction here was about 7%, but it was clearly not statistically significant. So this is a bit like the results of the SHIFT trial with ivabradine, with the benefits apparently only on the non-fatal component of the composite outcome. So we don't know what's going to happen with this drug. Obviously, we'll have to undergo regulatory review, and if it's approved, then it will be another option available to us in clinical practice. So that takes me up to date with HFrEF. So you can see that we continue to make amazing progress with all of our different drugs, but it does leave us with a lot of choices. I think everybody would agree that these are core therapies, but are what the Americans would call foundational therapies. And then we've got all of these other treatments, 4 different therapies that have been added. Essentially, these are all added to these 3 core therapies. We have to figure out which of these to use and in what patients. And I think I have a very simple summary of this. I would say the 5 pillars of HFrEF therapy, the 5 life-saving therapies, so I've abbreviated this to the 5 alive, are these drugs. They all act through different mechanisms. We believe they all act on different pathophysiological pathways. We believe their benefits are complementary and additive. And very importantly, from the patient point of view, although I'm talking about 5 pharmacological approaches, we're talking about 4 pills, because 2 of these pharmacological approaches, 2 of these mechanistic pathophysiological interventions can be achieved using 1 tablet, and of course that's sacubitril valsartan. So if there's one important picture I think to take away in your mind about HFrEF, I would suggest it is this one. So this is where we're at with HFrEF. We have to figure out how to use all of these drugs, and I think the million-dollar question today is about how we sequence them. What order do we prescribe these in patients with HFrEF? I'm not going to read out all the words in this slide, but these are the things that I think about when I'm deciding what treatment to use first, second, third. So I think about volume status, I think about blood pressure, I think about potassium, I think about renal function. The drugs are all different, and there may be patient characteristics that might make you choose one treatment over another. And I think the other thing to think about is this, and I pointed out to you twice. First of all with sacubitril valsartan, and then secondly with dapagliflozin, that we are seeing benefits of these drugs within 1 month of starting treatment, in fact less than 1 month. So time is of the essence. The longer you delay in starting these treatments, the more patients, and I hate to say this, will die because of our inertia, because of our delaying getting them on treatment. So time is of the essence, and I do think that we also need to take into account how quickly we can get these treatments started and up titrated. And there is definitely a difference between these treatments in terms of their ease of use and speed of up titration, where we go from dapagliflozin, it was a single dose in everybody, all the way through to the more conventional drugs that we use, where traditionally we've maybe used 3 or 4 different dose steps before we get patients to full dose. So I'm going to finish now by saying something very quickly about heart failure with preserved ejection fraction. As you heard in the first presentation, this represents about half of all patients with heart failure, we believe. Last year was a very busy year for me. We also published the Paragon heart failure trial, And you know the design of this was our sister study to Paradigm heart failure. And in Paragon heart failure, unfortunately, we just missed statistical significance. You can see here that overall, there was a 13% relative risk reduction in the primary composite endpoint, which is cardiovascular death and heart failure hospitalization, both first and repeat events. You can see that the upper 95% confidence interval just crossed 1. The p-value was just larger than 0.05. And when you break that composite endpoint down, you can see that unlike HFrEF, cardiovascular mortality is actually much less common than heart failure hospitalization. So this is about 12% per year. This is about 3% per year. And you can see that there was an approximately 15% reduction in heart failure hospitalization. Again, not quite statistically significant. Absolutely zero effect on cardiovascular death, although we never thought we would show an effect in cardiovascular death because we realized it was actually occurred at a relatively low rate in these patients who often die from non-cardiovascular causes, which we knew that we could not modify with a drug acting on neurotumoral systems. The intriguing thing that we found in Paragon, something that we hate to find in studies, was subgroup interactions. And the most striking subgroup interaction was the interaction with baseline ejection fraction. We said before we ever unblinded the data set in a pre-specified subgroup plan that we would look at patients with an ejection fraction above the median value, which happened to be 57%, and patients with an ejection fraction at or below the median value. What you can see here is this apparently greater benefit in patients with an ejection fraction below 57%. Those patients where today, many of them would be described as having heart failure with mid-range ejection fraction rather than heart failure with preserved ejection fraction. And this shows you the relationship between the effect of sacubitril valsartan and ejection fraction. So this is a continuous rate ratio. You can think of this as a hazard ratio. If it's below 1, that indicates benefit of sacubitril valsartan over valsartan. And you can see that the hazard ratio is below 1 up to about 60%. And then clearly the hazard ratio is not below 1 in patients who've got a completely normal ejection fraction. Now, the problem about this is, of course, that we tend generally not to believe subgroups. We always are concerned that they've occurred by chance and that they might not represent a real finding. But we have reason to believe that this might be real because we've seen the same finding with candesartan in the CHARM program and with spironolactone in the TopCat study. So it is possible that this might be a true effect. And the reason that that's important and the reason we need to look into this further, try and understand it better, is that if it is true, in other words, if there really is a benefit in those patients with an ejection fraction of less than, say, 60%, then the absolute benefit is actually very substantial and could be clinically very worthwhile. So at the moment, we're trying to understand this interaction better. There are discussions ongoing with the regulatory authorities. The guideline committees are also having to think about this. So I think we all have to watch this space. It may be that the conclusion is that this is not strong enough to recommend sacubitril valsartan. On the other hand, it is possible that there may be a recommendation that it is valuable in patients with an ejection fraction that is below normal, but not in the clearly reduced range. So last thing, 1 or 2 slides is to try and look at the road ahead. So what will we be seeing in the near future? Well, there's lots still happening. These are the main large morbidity mortality trials that are currently underway. We've another SGLT2 inhibitor trial in HFrEF due to report in about 2 months' time, in fact, under 2 months' time at the European Society of Cardiology. And in November of this year at the American Heart Association, we hope to report on this drug called omecamtiv mecarbil, a drug that improves left ventricular systolic function. It's not an inotrope in the classical sense, but it literally goes to the heart of the problem in patients with reduced ejection fraction, increases systolic performance, doesn't lower blood pressure, doesn't affect renal function. If this trial is positive, it could be a real game changer. And it's a huge trial. It's just closing out at the moment. It's over 8,000 patients. It's got the same primary endpoint as all of our trials, but it is big enough actually to look at mortality as well. So this is a placebo-controlled trial, adding omecamtiv mecarbil to conventional therapy. It will give us a very robust result. I don't know whether it will be positive or not, but if it is, it'll be a very important addition to our therapeutic options for our patients. So 2 more big trials, hopefully reporting just this year, 2020. There are many other SGLT2 inhibitor trials underway, and the 2 I want to specifically mention are the 2 that are looking at HFpEF. So these are the 2 big trials currently ongoing in HFpEF, both large, 6,000 patients approximately. This one is fully recruited. This one is nearly fully recruited. We'll get the results of these in the next year and a half, so about 18 months probably until we get the results of these studies. And then you may have heard just about a week ago, an announcement was made that we will be starting another large HFpEF trial, again targeting over 5,000 patients using this new type of mineralocorticoid receptor antagonist. It's what's described as a non-steroidal mineralocorticoid receptor antagonist. It's more specific for the heart. We believe it's less likely to cause hyperkalemia and renal impairment. This is a placebo-controlled trial, and we will be starting this after the summer vacation in Europe. So this should get underway in September. So to summarize and conclude, these have been very exciting times in heart failure. We continue to make progress. I've told you about the new trials over the past 5 years, 2 reducing mortality, another one just this year showing a benefit in heart failure hospitalization. We're studying more mechanisms in more trials than ever before. We've even continued to do things in HFpEF. We've just completed Paragon. These 2 trials are currently approaching completion. And as I've just mentioned, there's another new HFpEF trial just getting underway. So thank you very much, and I'm happy to answer any questions you might have.
Okay, thank you very much, Professor McMurray, for this elegant talk as expected. Actually, we have loads of questions regarding sacubitril valsartan, regarding other new therapies in heart failure. And if you don't mind, we'll have the talk of Professor Magdi Abdelhamid, which will be for about 15 minutes. Then we'll open questions because we have to collect all those questions and filter the repetitives. And once more again, thank you very much, Professor McMurray, for this elegant talk and extensive review of new anti-heart failure therapy. And we hope to see you soon again in our meetings, which will be very successful. Now I move to Professor Magdi Abdelhamid, and we are very honored to have Professor Magdi Abdelhamid with us. He is the immediate past president of the Egyptian Society of Cardiology, and he's the chairman of Heart Failure Working Group, and he has extensive experience in heart failure, and has published several papers regarding heart failure epidemiology in Egypt, and recently one in the upcoming European Society of Cardiology was about sacubitril valsartan in Egyptian patients. So Professor Magdi Abdelhamid, thank you for being with us, and now the mic is for you.
See my slides?
Yeah, it's clear.
Yeah. You hear me?
Yeah, we hear you very well.
Okay. Thank you very much, Professor McMurray, for this amazing presentation. And I'm expecting a lot of questions and fruitful discussion at the end of this day. Thank you very much, Professor Ahmed, for the kind introduction. So in a couple of minutes, I will give you a brief for the practice of heart failure in Egypt. So I will start. This is interesting slide, which showed the Egyptian Society of Cardiology, which was founded in 1951 by Professor Muhammad Ibrahim. It's a non-profit organization. And the Egyptian Society of Cardiology comprised of 17 working groups. The all working groups work actively to deliver the best updated practice in all subspecialties. And we are one of the national cardiac societies of the European Society of Cardiology since 1965. As we know that, as mentioned by Professor Ahmed, that cardiovascular disease represent the leading cause of mortality worldwide. And this is exactly also in Egypt. If you look for this slide, 2014, the WHO, the non-communicable disease represent as a cause for mortality in Egypt, 85%. And the mortality due to cardiovascular disease is around 46% annually, mainly due to myocardial infarction and stroke. And this interesting slide shows that the oldest patient known to have coronary artery disease was an ancient Egyptian princess. This interesting study, which was published in the JACC Imaging by my colleague, Professor Adil Allam, and the co-authors, 2011, and they did the whole body multi-slice CT for a 52 mummies of the ancient Egyptian mummies to identify cardiovascular structures and arterial calcification. And we can see here the calcified left coronary artery and right coronary artery, and early findings which indicates the early discovery of coronary atherosclerosis thousands of years ago in the Egyptian princes. So this paper, which was published by 1 year ago in the European Heart Journal, which is an ESC Atlas data statistical analysis for the prevalence of cardiovascular disease. And we can see that hypertension represent around 25% in the Egyptian population. And unfortunately, diabetes in Egypt, 17.3%. And obesity is an epidemic in our country. For women, it's around 40% or more, and for men, 23%. So we have risk factors for heart failure. And as mentioned by Professor Ahmed, that heart failure is an epidemic disease all over the world. It represents 1 to 2% of the general population. And we have cardiovascular risk factors like hypertension, diabetes, obesity, which contribute to coronary artery disease, which is the main cause for heart failure in the Egyptian population, as we will see later. So the activities of the Working Group of Heart Failure, which I have the honor to be the president of the Working Group of Heart Failure, we are involved in all registries, European as well as international registries. And we are doing a continuous medical education regularly. The aim is to to implement the guidelines in the daily clinical practice, to be sure that our patients who have heart failure treated according to the guidelines. And we are doing a good research, and we are announcing every year for the Heart Failure Awareness Day to discuss for the population about heart failure, what's meant by heart failure, and an interactive discussion with the patients as well as the caregivers. And this is an important event. And we are doing a regular meeting every year for the working group of heart failure. Regarding the registries, we are participating in all registries related to the European Society of Cardiology. And if we look for heart failure, which was the ECC Heart Failure Registry 2014, we enrolled around 2,145 patients, which is a big number compared to other European countries. And we published our national data in the ECC Heart Failure Journal 2015 for the clinical characteristics and the management of hospitalized and ambulatory patients with heart failure, results from the ECC Heart Failure Long-Term Registry. My colleague, Professor Mahmoud Hassanini, was the national coordinator of the registry, myself and other colleagues from around 25 centers from Egypt. And if we look for our data compared with the European countries, for the hospitalized patients with heart failure, we can see that the age in the Egyptian patients was lower compared with European countries, 61 versus 73. Heart failure with preserved ejection fraction was lower compared to European countries, and this is due to mainly the age. But we have diabetes more compared with other countries, and the same for smoking, 61 versus 47. And if you look for the etiology, ischemic cardiomyopathy, post-infarction remodeling, and heart failure represent the main etiology in the Egyptian patients for the cause for heart failure. And if we look for the in-hospital mortality, it was the same, around 5%. And unfortunately, the use of devices is much lower compared with European countries, 1.5 in the hospitalized patients versus 18.6%. And regarding the patients with chronic heart failure, the same, the age is lower compared with European countries. And if we look for the valvular heart disease, because still we have rheumatic heart disease as a cause for heart failure, so it is higher compared with European countries, 17.5 versus 8%. And again, the devices 2.2 versus 35%. So the use of devices in our country is lower, maybe the financial or the cost issue as a cause. Beta blockers, 6 years ago, the use of beta blockers was lower, 67 versus 8.9. But I think nowadays, beta blockers, we know that it's a cornerstone for treatment of patients with heart failure. And digitalis or digoxin was used more in the Egyptian patients, 47%, maybe due to high prevalence of atrial fibrillation in those patients. So the conclusion of this manuscript or our national data that we have different demographic characteristics for heart failure patients compared with the European countries, mainly the lower age, the age is younger, more compared with the European countries. And ischemic cardiomyopathy is the main cause for heart failure in those patients. What about gender difference? Is there a difference between men and women with heart failure? Because this is a very important question, because we know that the women are underrepresented in the clinical trials in heart failure. So in a paper also which was published in the ECC Heart Failure Journal 2 years ago, we compared the outcome and the demographic characteristics of heart failure patients, men and women, involved in the ECC Heart Failure Long-Term Registry. And we can see that obesity was much higher in women compared with men. And ejection fraction more than 50, which is HFpEF, is more in women than men. Atrial fibrillation also was high in women compared with men. And the comorbidities like anemia was more in women compared with men. And this is data regarding the history, cardiovascular risk factors, and the primary etiology. And we can see that ischemic cardiomyopathy was the main cause. Smoking was more in men, diabetes more common in women, COPD more common in men than women. And if we look for the in-hospital data and the precipitating factors and the mortality, we can see that atrial fibrillation was more common in women, and anemia the same, and the in-hospital mortality and 1 year mortality was more or less the same in men and women. So the conclusion that men and women with acute heart failure have different clinical characteristics and management. These findings emphasize the importance of individualized management and the need for more recruitment of women in clinical trials. Nowadays, we are participating in the ongoing Heart Failure 3 registry, the European Heart Failure Registry 3, and we started to enroll patients at the end of last year, 2019, and we are recruiting the patients from 25 Egyptian centers. And the importance of these registries, it focus on implementation of EC heart failure guidelines in the daily practice, and it improves the use of evidence-based therapy, so it improves the outcome, and it allows the education and screening for patients, and the registries also can be considered as a platform for randomized controlled trials. Also, we participated in important registry, which was an international registry known as Report Heart Failure for patients hospitalized with acute heart failure. And the main objectives is to define the baseline and demographic characteristics for patients admitted with acute heart failure regarding the etiology, regarding whether it's acute decompensated heart failure or it is acute heart failure de novo, or precipitating the factors, the management strategy, the in-hospital course, in-hospital morbidity and mortality, as well as 30 days rehospitalization, and also focused on the health resource utilization, the main interest in this registry. And among the Mediterranean and North Africa countries, we participated in this registry with a total number of 2,241 patients. And the conclusion of this registry that this is the first global acute heart failure registry collecting contemporary data regarding the patients who admitted with acute heart failure. And there is a similarity in these data and the management strategy during the index of hospitalization, although there is a diversity in some management strategies. However, these data are important to identify the predictors for the outcome and the limitations for treatment strategies which are used in treatment of acute heart failure patients. Regarding the implementation of guidelines in the daily practice, especially the heart failure guidelines 2016, and we are usually using these guidelines as a case-based discussion. And last year we did a very interesting event, which is Cardiology Updates 2019, endorsed by the European Society of Cardiology, focusing on the guidelines mainly, and the opening ceremony here by the introduction speech by Professor Barbara Cassidy. She's the president of the European Society of Cardiology. And the new EC guidelines 2019 for diabetes and pre-diabetes and cardiovascular disease was presented elegantly by Professor Francisco Cosentino. And regarding the original research, this is a very interesting new research, which was I presented in the heart failure meeting 2018 in Vienna. New renal hemodynamic indices, which can predict worsening of renal function acute decompensated heart failure patients. My co-authors, Dr. Karim Saeed, Dr. Walid Ammar, Dr. Amir Mustafa, from the cardiology department, Cairo University. And this is a challenging subject because we know that worsening of renal function and the rise of serum creatinine is common in patients admitted with acute decompensated heart failure. And the cutoff level for definition of cardiorenal syndrome or worsening renal function is the rise of serum creatinine more than 0.3 milligram per deciliter. And although we know that there is limitations and the challenges in identifying patients who are liable to develop cardiorenal syndrome, we used a new tool, which is non-invasive tool, bedside renal duplex, to study the renal hemodynamics regarding the resistivity index, which equal peak systolic velocity minus end diastolic velocity divided by the peak systolic velocity, which is normally less than 0.7. Pulsatility index, peak systolic velocity minus end diastolic velocity divided by the mean velocity, which is normally less than 1. And the acceleration time from the beginning of systole to the peak to the maximum systolic velocity, which is normally less than 70 milliseconds. And we concluded in this study that worsening renal function occurs in 40% of patients hospitalized with acute decompensated heart failure treated with diuretics, and intrarenal duplex parameters like renal resistivity index and acceleration time are independent predictors of worsening renal function in hospitalized patients with acute decompensated heart failure on diuretic therapy. Higher admission renal resistivity index is associated with lower diuretic response, and worsening renal function is an independent predictor of adverse outcome in hospitalized patients with acute decompensated heart failure. And last week, we published this paper in the ECC Heart Failure Journal as an original research article. And we can see that renal acceleration time and the independent predictors for worsening renal function were renal acceleration time at 24 hours and admission values of renal resistivity index, two important predictors which can identify patients with acute decompensated heart failure who develop worsening renal function. And this interesting paper, the ECC Cardiopol on Twitter, they put this voting for the study, do renal acceleration time and resistivity index assessed by intrarenal Doppler ultrasound represent independent parameters that can help identify acute decompensated heart failure patients at high risk of worsening renal function. And 57% answered the true, 6% false, and 37% I need more data regarding this tool. So it is a non-invasive tool, bedside tool, a new tool, which can identify patients with acute decompensated heart failure liable to develop worsening renal function and the cardiorenal syndrome. And also we have registered the study for sacubitril valsartan. What is the real world evidence? And this is considered the first Egyptian study looking for the impact of sacubitril valsartan in Egyptian patients with heart failure and reduced ejection fraction. 6 months follow-up to see the clinical and echocardiographic outcome of sacubitril valsartan in heart failure patients with reduced ejection fraction. And we presented this data also 2 weeks ago in the Heart Failure Discovery virtual meeting. And we can see here that we compared the different doses of sacubitril valsartan, 50 milligram, 100 milligram, and 200 milligram. We observed that different doses are associated with clinical improvement, NIHA class questionnaire of heart failure regarding exercise capacity. But what about ejection fraction, which is an important parameter should be looked for patients who have clinical improvement? Because we know that the reduction of NT-proBNP was translated into improvement in cardiac structure and function. And this was proved in the Proof Heart Failure trial, which was presented last year, the favorable effect of sacubitril valsartan on parameters of remodeling. So regarding the 50 milligram dose, we observed that there was improvement in terms of reduction of left ventricular end-systolic volume, but no increase in the ejection fraction. But compared with the 100 milligram and 200 milligram doses, we observed a significant reduction in parameters of LV remodeling, reduction in end-diastolic volume, end-systolic volume, as well as increase in the ejection fraction. So this study proved that the use of sacubitril valsartan was associated with significant improvement in exercise capacity, NIHA function class, quality of life, and the echocardiographic findings, reduction of end-systolic and end-diastolic volume, increase in ejection fraction, and decrease in pulmonary artery pressure. But this favorable effect was noted in patients with high baseline blood pressure, because those patients can tolerate higher doses of sacubitril valsartan. And in the same study also, we can see that the increase of ejection fraction by 5% or more was observed in 51.6%, while the ejection fraction increase by 10% or more was achieved in 23.7%. So sacubitril valsartan had shown improvement in cardiac volumes, ejection fraction, and this is very important observation, which can be achieved with the use of sacubitril valsartan in a high dose. And we can see here the significant reduction in the NT-proBNP level, significant reduction in the number of hospitalization. Every year we celebrating a very important event, which is Heart Failure Awareness Day, which is also supervised by the EC. And this year, the EC was planning for giving the best 3 countries organizing such an event. And usually we are doing sport activities in the early morning as an outdoor activity. And we are doing during this Heart Failure Awareness Day, this is CPR sessions to educate lay people how to resuscitate patients CPR. And also we are doing indoor activities with patients, patient engagement and interactive discussion for patients and caregivers to answer all questions related to heart failure and how to give the best care for heart failure patients. And the board of the working group heart failure giving presentations for patients and the caregivers and answering all questions related to heart failure. In addition, again, CPR sessions, and this event covered by the media. And this is a very important event. So also during the World Heart Day announcement for heart failure causes and some important data regarding heart failure. And this is a printed material for patients answering all questions related to heart failure. And we have been recognized by the European Society of Cardiology, Heart Failure Association, the Egyptian Society of Cardiology, one of the winners for the Heart Failure Awareness Day. Thank you for your attention. Thank you very much.
Thank you, Professor Magdi Abdelhamid, for being with us. And actually, it's a great honor to be with us. I'm not sure why my camera is not working. Anyway, it's working now. Actually, it's a very nice presentation by Professor Magdi Abdelhamid. And I'd like to start questions. And I have my colleague, Professor Ihab Salim, he has some important questions about is one of the important drugs, actually, which is SGLT2 inhibitors, being a cardiologist, to Professor McMurray. Look here.
Thanks, Professor McMurray, for this informative lecture. We made us look to the future with optimism. Thanks, Professor Magdi, for his elegant presentation, made us stand on our own ground in practice. The question is to Professor McMurray about DABA half-rev. In the study, the mean age is about 66. When you use any SGLT2 co-transporter inhibitor as an anti-diabetic medication, we use this with extreme caution, especially in old age and with concomitant use of diuretic for fear of volume depletion, hypotension, and especially also the extreme age, senile enlarged prostate, because some patient may complain from nocturia and the risk of DKA. What does regard the safety and tolerability issue in the subgroup of old age patient in this study?
Okay, thank you very much for that question. So, in fact, we have published a paper about our experiences in older patients in Paradigm in DAPA-HF, and in fact, the oldest patient we enrolled, if I recall correctly, was 94 years of age, and we found entirely consistent benefits across the spectrum of age. It was really quite remarkable. And not only that, in fact, if you're interested, I can actually show you that. Here you are. I hope you can see my screen. If you can see my screen,
yes, I see.
Then what you can see here, this green line is a continuous. Let me get my pointer right. Sorry. Anyway, not to worry. This green line is a continuous hazard ratio. So the red interrupted line is hazard ratio of 1, so that would mean no difference between DAPA and placebo. Hazard ratio below 1 indicates benefits, and here is the continuous hazard ratio across the range of age. And there was absolutely, completely consistent benefits. And what was even more remarkable is what you can see in this slide. So here you see patients broken into different categories. This is looking at safety. If you look here at renal safety, so the bold is the placebo group. So in people aged less than 55 years of age, 4% of patients on placebo had an adverse renal event. It was 11% of patients in patients aged 75 years of age or older. So older patients experience more renal dysfunction, but remember this is placebo. But now compare within the age groups between DAPA and placebo, and look at this. This is the oldest patients. They were actually less likely to experience worsening renal function in the DAPA group than the placebo group. And in fact, we found that whatever adverse event we looked at, there was no excess in older patients. So the efficacy and safety profile of dapagliflozin was remarkably good. Here is people discontinuing study drug. So for any reason at all, so that's a good indication how well tolerated a drug is. During the trial, you don't know what the patient's taking, they don't know what they're getting, but for whatever reason you decide, I'm going to stop this drug, I don't like it, the patient doesn't like it, there's something wrong. 8% of young people, younger people, stop placebo, 11% of younger people stop dapagliflozin. Look at the patients aged 75 years of age or older. So in the placebo group, it was more people stopped treatment because more things happened to older people. But remember, this is placebo. Now compare placebo and DAPA, and you can see here, in fact, there were fewer people stopped DAPA than stopped placebo in the 75 years age group or older. And all of this is published in great detail in a paper in Circulation in January of this year. And we even in this appendix look at the subgroup of people aged 80 years of age or older to really focus on very elderly patients. And it's the same story, very effective, very well tolerated. We did not see any concern in older people.
Thanks, Lucia. You expect this is a class effect or the drug effect as regard SGLT2 co-inhibitor?
Well, I would have said a class effect until about 2 weeks ago, but you probably saw the versus CV presentation at the American Diabetes Association Congress. So that was the last of the large type 2 diabetes trials to present. I was using a drug called ertugliflozin, and it actually seemed to be different. I don't know why. It might just be chance, but it was a really big trial, really good trial, very like EMPA-REG outcome in design and patient population, but no effect in the primary endpoint, no effect in cardiovascular death. There was a reduction in heart failure hospitalization, but again, when it came to renal events, there wasn't the same renal protection. So maybe there is a difference between drugs in the class. I normally don't think that, but definitely versus CV appears to be different than the other large SGLT2 inhibitor trials.
The last question for me. There is another anti-diabetic medication similar to SGLT2 in its effects as regard not causing hypoglycemia, cause more weight loss. There's a cardiac beneficial effect, but in the ground with atherosclerotic cardiovascular disease, which is GLP-1 receptor agonist. Do you expect that GLP receptor agonist will find its place similar to SGLT2 as regard the atherosclerotic cardiovascular disease in the future?
So I agree with you. I completely agree. We published a meta-analysis. I led a trial called Harmony Outcomes. I think GLP-1 receptor agonists are great drugs for patients with type 2 diabetes. As you correctly say, their predominant effect is in stroke and myocardial infarction. SGLT2 inhibitors, mainly heart failure. It makes sense to use the two types of drugs together in patients with type 2 diabetes. I agree.
Yes, thank you.
We have a lot of questions, Dr. Ahmed. Can I ask, or we will ask a question?
You will ask him.
Okay. Okay. I will start by a question, Professor McMurray. You know that the reduction of NT-proBNP was comparable with the improvement in cardiac structure and function. But why NT-proBNP did not identify patients who benefit more from sacubitril valsartan in the Paragon trial, although the NT-proBNP decreased by 19%. However, there was no improvement as compared with Paradigm.
I'm not sure I follow the question. I apologize. So what's not improved compared to Paradigm?
We observed that although the NT-proBNP in Paragon decreased significantly by 19%, however, did not translate into improvement in cardiac structure and function compared with Paradigm.
Well, we don't know about cardiac structure and function because we never measured that in Paradigm, and we haven't really done that analysis. That I don't think we've got the echoes to do that analysis in Paragon. We have baseline echoes in Paragon, but if you're talking about why did the reduction in NT-proBNP not lead to reduction in clinical events, then I think it all depends on whether you interpret Paragon as showing no effect or a small effect that was a borderline significance, or whether that, if there is a benefit, it was concentrated in people at the lower end of the ejection fraction range. And of course, those are the people who had higher natriuretic peptide levels at baseline, and those are the people who had a greater reduction in NT-proBNP. In fact, the reduction in events in Paragon is probably proportionally consistent with the more modest reduction in NT-proBNP. We did not see as large a reduction in NT-proBNP in Paragon as we saw in Paradigm. So I don't think the size of effect on NT-proBNP and the size of effect on clinical events, I don't think that's discordant. I think it's consistent.
Okay, may I ask a question, Professor McMurray, about the?
You can ask anybody else a question if you want.
Thanks, Professor McMurray, and I hope that we didn't put a lot on you, and I know it was a long day for you, so I hope you are enjoying our discussion. So about evidence of structural remodeling in heart failure. We have some trials, which is the BOOF trial, and other trials with sacubitril valsartan is doing some sort of reverse remodeling in LV, reverse remodeling in LV ejection fraction, reduction of LV in systolic diameter and dimensions, LV and diastolic, reduction of MR, and reduction of pulmonary hypertension and LA size. What's your experience about that? Its implications in clinical practice?
So I hate to say this, but I disagree with that interpretation of PROVE, because PROVE was an observational study. It was not a randomized trial, and observational data are always misleading. So you and I both know that if we start people on other drugs, we follow them up, it takes up to a year before you reach the eventual plateau in improvement that you will see in LV remodeling. For example, we know that with beta blockers. And therefore, for all I know, a lot of that improvement in LV remodeling in the PROVE trial may have just been what was happening with other therapies and the natural history of what's going on. So in fact, I think there are very few data telling us anything about the effects of sacubitril valsartan on LV remodeling. I don't think that's necessarily a bad thing, but I think that's the truthful situation. We have actually just completed a trial, a cardiac MRI trial. The database will shortly be locked, where we've compared sacubitril valsartan to valsartan in a proper prospective randomized 1 year long cardiac MRI LV remodeling trial. So we will have data on that. What's my impression in clinical practice? I think it's very difficult to tell, because there are very few patients where the only thing you do is give them sacubitril valsartan. Usually you're changing other things. And yes, a lot of people seem to improve over time. But was that because of the beta blocker I started 2 months before, or the eplerenone, or sacubitril valsartan, or were they going to improve anyway? Very, very difficult to know. Unless you've got a controlled trial, you simply can't tell. What do I think happens? So what would be my guess? I'm sure there is an improvement in LV remodeling, but strangely enough, the best data for any recent drug is actually with ivabradine. And in the SHIFT investigators had a really excellent LV remodeling study built into their trial. So that's actually the only large data set that we have for any of the new drugs. Vericiguat seemed to do nothing. Sacubitril valsartan, we don't know. Dapagliflozin, we definitely don't know. As I say, ivabradine is the only one where there are actually strong data. And there was an improvement in LV remodeling, and that's what I would expect, I think, with any effective drug.
Thank you, Professor Magdi.
We got some questions from the attendees, so we will try to answer 2 or 3 questions. One question asking Professor Joe McMurray about the new guidelines after these promising drugs, the role of dapagliflozin and vericiguat in the new guidelines. What's your expectation?
Okay, so I have to be careful what I say here. So anything I say is my personal opinion, okay?
Yeah.
Just mine, not speaking on behalf of any guideline committee. And I'm certainly not talking about vericiguat because it's not approved anywhere. So until a drug is approved for used by a regulatory authority, I don't think it's appropriate to speculate. In terms of SGLT2 inhibitors, I think if the Emperor reduced study, which we'll hear about in August, confirms the results of DAPA-HF, then an SGLT2 inhibitor will have a class 1 level A recommendation. So it'll be a very strong recommendation, essentially saying you should use it. The debate, I believe, is about when, where in that algorithm does it fit? And I think that's really where the discussion is at the moment. Now, I think nobody disagrees about where it is for a patient who's diabetic. If you have a HFrEF patient who's got diabetes, it's right at the top of the list. So if you want to focus where I think all the discussion in the guideline committees is, it's about where do you place an SGLT2 inhibitor in a HFrEF patient who does not have diabetes? Does it come at the same level as sacubitril valsartan? Does it come after? Where do you put it? I think it will, in the guidelines, always probably be after a RAS blocker, beta blocker, and MRA, because guidelines are like that. You have to follow certain rules. You have to follow the trials chronologically. You have to look at what background therapy people were getting. But if you think about it, I showed you a slide, in fact, where all of these new drugs were all tested on top of ACE inhibitors, beta blockers, and MRAs. So in a sense, they're all at the same level, and you have to choose amongst them what you add next. So that's what I think will happen. They'll definitely be there unless we get a real surprise in August. They'll be right at the top for patients with diabetes, but probably be further down for patients who don't have diabetes. And there'll be a lot of discussion about where that will be. In practice, what I think will happen is, and I think sacubitril valsartan and dapagliflozin are like both of my children. I don't wish to choose between them. I love them equally, but I suspect in practice, SGLT2 inhibitors probably easier to use. No titration, single dose, effectively no reduction in blood pressure, virtually no effect in renal function. So in some ways, they're easier to use, but the two drugs are complementary. And my plea to everybody would be, remember that 5 alive, 4 pills. That's the key.
Thank you very much for your perfect reply. By the way, Professor McMurray is a member of the higher committee in the NICE guidelines, in the European Society of Cardiology guidelines for heart failure, and the committee of American College of Cardiology as well. So I know that you're speaking on behalf of yourself only. We have some question about how to start poly heart failure therapy in patients with heart failure with reduced ejection fraction. So can you combine sacubitril valsartan with SGLT2 inhibitors? This is
absolutely, definitely. Yeah. So I don't know from a trial about adding sacubitril valsartan to an SGLT2 inhibitor, but I do know from a trial about adding an SGLT2 inhibitor to sacubitril valsartan, because as you know, we had over 500 patients in DAPA-HF who were on sacubitril valsartan. We added dapagliflozin or placebo in those patients. There is a paper that is maybe even published today. I haven't checked, but it's imminent. It will be published any day now, going through in great detail our experience of what happens when you added DAPA to sacubitril valsartan. So at least in that direction, I know that the benefit was just the same. The reduction in blood pressure was just the same. The change in renal function was just the same. There was no intolerance, no more intolerance than with placebo, but the same benefit. So I know that you can add dapagliflozin on top of an SGLT2 inhibitor and everything's okay.
Yeah, and the same question. What's the higher level of left ventricular ejection fraction that you will give either sacubitril valsartan? Would you go above 35%?
Oh, definitely.
Yeah, 40.
So,
55?
well, I personally wouldn't go above 40. So about 25%, roughly, about a quarter of all patients in paradigm heart failure had an ejection fraction between 35 and 40%. It's 2,000 patients, a lot. And they got exactly the same benefit, exactly the same relative risk reduction as the other patients. We saw a completely consistent effect across the spectrum of ejection fraction. That paper is published. Circulation Heart Failure, Scott Solomon is the first author on that. So there's no question about that. Now, it's a very interesting question. Above 40%, that's where all the debate is. So you probably know that this so-called mid-range ejection fraction is probably going to be renamed. So instead of talking about heart failure with mid-range ejection fraction, we're probably going to talk about heart failure with mildly reduced ejection fraction. So same initials, different words. And that's because we think those patients really have a lesser degree of systolic dysfunction. And if you believe that, if you are willing to accept that, then all the drugs, not just sacubitril valsartan, all the drugs that work in systolic dysfunction should work in those patients. Now, I'm personally not at the stage of doing that in practice. If I have somebody whose ejection fraction is around 40%, I'll give them the benefit of the doubt, is the way I would express it. In other words, I'll be generous. I'll say, well, there's an error around ejection fraction measurement of plus or minus certainly 5%, maybe even 7%. So if they're borderline, then I'm willing to treat them because I want to make sure I'm doing the best for them. But am I treating people with ejection fraction of 49%? No, I'm not.
Okay, thank you.
But according to the sub-analysis of Paragon, do we have enough evidence to recommend the use of sacubitril valsartan in HFpEF patients like women, for example, even though the ejection fraction 50%?
Okay, so that's such a complicated question. That's such a good question because so the story there is really interesting because, as you know, women, I was going to say women are different than men. I think we know that. Women are different than men when it comes to ejection fraction. So women have a different normal range of ejection fraction. Women with heart failure have a different range of ejection fraction. You showed that in some of your slides. And a woman who has an ejection fraction of, say, 55% has systolic dysfunction. But a man who has an ejection fraction of 55% has got pretty normal systolic function. So that interaction between women and men may be the same interaction as we saw with ejection fraction. In other words, we published actually recently on this, looking at CHARM, looking at MRA trials, and looking at Paragon. If you look at that relationship between treatment effect and ejection fraction, the benefit of all of those drugs seems to extend to a higher ejection fraction in women compared to men, consistent with the idea that women have a different normal range and that what might be normal for you and me might represent systolic dysfunction, mild systolic dysfunction in a woman. So it is quite an interesting story about how these two things, sex and ejection fraction, are so intertwined.
So, if a patient with heart failure and reduced ejection fraction, he was 37% ejection fraction, and he's improved on sacubitril valsartan, and his ejection fraction now become 47, 49, maybe 50 plus. Would you stop or reduce the dose of sacubitril valsartan, or you will continue, and for how long?
No, I wouldn't stop. So until recently, I would have said I wouldn't stop because my experience of doing that which I have to say has been mainly in women with peripartum cardiomyopathy, is that quite often people will deteriorate. And you might say, well, that doesn't really matter because you can restart treatment. But the problem is that you restart treatment and they don't get back to where they were. So that's my anecdotal experience. But actually, you probably know there was a trial called TREAD-HF. You mentioned John Cleland. He was one of the authors on this paper published in The Lancet. The first author was Halliday. And that was a randomized withdrawal study. And what it showed is, I think about a third of patients on withdrawing treatment had a clear deterioration, and I wouldn't do it. I mean, sometimes you're forced to do it because patients insist, but generally speaking, I wouldn't do it. I think you have to assume, I mean, there's always exceptions, so nothing's ever 100%, but generally, I think you have to assume if somebody's got heart failure in the low ejection fraction and it gets better with treatment, it's probably a reasonable assumption that the reason it got better is because of the treatment. And why would you risk putting them back to where they were? So my short answer would be no.
Dr. Magdi?
Yeah, people are always asking about diuretics with the new drugs, how to handle the diuretics with sacubitril valsartan, with SGLT2 inhibitor, versus what also there is an interaction. So what is the tips and tricks of diuretics with these drugs?
Okay, so I think there's a bit of a myth around that sacubitril valsartan has diuretic properties. It doesn't. But SGLT2 inhibitors do, but again, they're probably short-lived. I mean, sometimes it's a matter of days, probably at the most 2 weeks, and there's no more apparent diuresis. So the tips and tricks, I think, are with not just for sacubitril valsartan or dapagliflozin, it would be true for an ARB or an ACE inhibitor and an MRA as well, is that if you think your patient is a bit dry, if they've got no signs of congestion, if their JVP is flat, if they're on a big dose of loop diuretic, you might want to think about reducing that before you start these other drugs, because we feel, I think our clinical experience, for what it's worth, is probably you're less likely to get hypotension and probably you're less likely to get deterioration in renal function. Now, it's interesting, we run a course, my colleagues now in Glasgow who all do heart failure, and we had a big disagreement about this. So actually one of your colleagues from Egypt was on that course recently, and he got us all arguing amongst ourselves because I recommended doing that before introducing dapagliflozin. But my colleague Mark Petrie, who some of you probably know, was absolutely adamant that he does not do that. He thinks it's a bad idea, that you don't need to do it. And you can start the SGLT2 inhibitor, then see your patient again, check how they're doing, and if necessary, reduce the dose of diuretic at that point. He's more worried that if you cut back on the diuretic before, you might actually cause the patient to get worse. So you're going to get lots of different opinions about that. But my own practice is, if I think the patient's on a big dose of diuretic, which in my books is more than 80 milligrams of furosemide or 2 milligrams of bumetanide per day, if the patient's got no evidence of congestion, then I would think about cutting back on their diuretic. And while we're at it, I think what's much more important, not so much with SGLT2 inhibitors, because they don't lower blood pressure. The only problem we really have with sacubitril valsartan is hypotension. So we always make a point of, if possible, stopping other blood pressure lowering drugs. If they're on a calcium channel blocker, usually there's no reason. If they're on a nitrate, usually there's no reason. If they're a man and they're on an alpha blocker because the urologist started it for prostatic obstruction, try, if possible, to stop those before you start sacubitril valsartan. And then I really do think, from my own experience, that you will reduce the risk of hypotension.
Ahmed?
صوت دكتور أحمد. Can I ask question until Professor Ahmed return?
I'm returning.
Professor McMurray, one of the exclusion criteria in the DABA-HFrEF is the type 1 diabetes. It is done, this classification is done on the clinical ground, or complete workup is done by C-peptide, other autoimmune?
No C-peptide measurement, nothing like that. Purely clinical. So it is possible that some type 1s may have slipped into the trial. We didn't carefully make sure that there were no type 1 diabetics. We just asked investigators not to include patients known to have type 1 diabetes. And you obviously know the reason for that, which is because of the greater risk of ketoacidosis in those individuals. Yeah.
Because it is difficult sometimes to diagnose type 1 from type 2. Sometimes type 1 diabetes present in the adult. LADA type, late onset autoimmune diabetes in the adult.
Oh, yeah.
Yes, and the clear example is the former Prime Minister, Theresa May, which diagnosed firstly as having type 2 and then discovered after complete workup to have a type 1. So, multidisciplinary approach is necessary before prescribing SGLT2 by cardiologist. If you please to me, because SGLT2 in a type 1, the type 1 diabetes, which wrongly diagnosed as a type 2, may precipitate serious DKA, and especially euglycemic DKA, which is difficult to diagnose because the random blood sugar is around 200, which is not a classic with the diagnosis of DKA.
Yeah, no, I mean, we would obviously not advocate starting. In fact, I would say if you want to be really cautious, if you have a heart failure patient, a HFrEF patient who's on insulin, it might be better to discuss that patient with your friendly endocrinologist, diabetologist, because even if it's type 2 and you're on insulin, you're at more risk, first of all, of hypoglycemia, and secondly, of ketoacidosis. And if, for example, you want to reduce the dose of insulin, you have to be careful in doing that. And I think those are the people to talk to your friendly diabetologist about. In DAPA-HF, amongst the diabetics, about 25% of those patients were on insulin at baseline.
Okay, thank you.
Because,
Professor, thank you, Professor Ihab Salim. Thank you, Professor McMurray, for the answering this question. We have just a couple of questions. One from Professor Magdi Abdelhamid first.
No, I was under
myself, actually, questions from the attendees. So Professor Magdi, then I will ask the last question.
You can start.
I was under the illusion. I was under the illusion that this meeting finished 23 minutes ago. What time are we running to?
I think we answered all questions that we have received from the attendees. So I don't have more questions which can be asked for Professor McMurray. If you have a question, Ahmed, please go ahead. Ahmed?
One question, Professor Ahmed.
Dr. Ahmed?
Professor McMurray exhausted a lot, and you.
I'm not exhausted. I was just wondering.
We can finish the day because.
I can close if we don't have more questions.
I don't mind answering some more questions, but I wasn't sure. I wondered if I got the time wrong.
I know it's a very long day, Professor McMurray. So at the end of this successful webinar, I'd like to thank Professor Joe McMurray for joining us today. And we enjoyed too much with his wonderful presentation and the fruitful discussion. So thank you very much, Professor Joe McMurray.
Thank you.
And we are looking to see you again on August, last of August, okay? At the end of August. In another international webinar organized by the Working Group of Heart Failure, the Egyptian Society of Cardiology.
So I will agree in one condition, that you answer all the questions next time.
Thanks a lot, Professor John McMurray. This is a great historic day in the ISMA history of association. By the end of this unique scientific day, on behalf of the ISMA board and member, great thanks for kind acceptance of our invitation, and we hope to see you in Egypt, in Ismailia, which is a beautiful city near after epidemic era of COVID-19 epidemic can regress and end. Thanks a lot, Professor Magdi Abdelhamid. You add great value to our meeting, and we hope that you see you again after 10 days. Thank you for all attendees. And end, Professor Magdi.
Thank you very much, Professor Ihab, Professor Ahmad, Dr. Ashraf Badawi, and the whole team of IRIS for the excellent organization for this wonderful webinar. Thank you very much.
Thank you very much for having me as your guest.
Thank you very much, Professor McRae. See you again. Bye-bye.
Yeah. Sorry, my connection has just lost and
lost.
resumed. I'm not sure whether you have closed the session or not.
خلصنا. Finished. Dr. Ahmed.